treatment of that because they've been wanting narcolepsy or non-narcolepsy patients to try narcolepsy for only proven drugs for hypersomnia. Which then we were feeling is, yeah, no, it's not the treatment of that, it's prescribing it for that. Then the drug insurance companies are wanting to dictate care. It's just hoops to jump through sometimes.
How knowledgeable are the people that you're trying to get a pre-approval?
The insurance companies,
I get a couple of them that are neurologists, but I think that's if it's doctor.
when it's doctor to doctor, that's it. When they're just going through reviews, it's just whoever's reviewing it and.
Yeah. Okay, so this is what are emergencies? Here's a case that 59-year-old male, long story starts 8 years. I've been really looking at how long do you have sleep apnea before you get clinically recognized? This is interesting literature. Sleepiness, hitting a rumble strip 3 to 4 times a week, wakens with chest discomfort, pain, subsides as he sits by the bed, takes Prolix, and he has those medications with a little bit of blood pressure, saturations probably okay for a 59-year-old melatonin chest. I mean, pretty clear here. So what do you want to do? What's the appropriate response to the rumble strip for you?
Is it getting strong and driving?
Yeah, I mean, you do that for 2 reasons. One is that they may not be aware of what's going on. Rumble strips are the most effective technology for drowsy driving that we have on the road. It's not your Mercedes-Benz lit alert or pupillary instability or things of that sort. It's the rumble strip. And the other is that you need to document that, because if the guy goes out and a week later goes across the median and hits somebody and dies, you could be a third party because you failed to warn. So what's the appropriate is the first thing to do? Various things. So I think you sort of know that you have these things you can do. You might want to do almost some of these, but you certainly don't want to develop a GI endoscopy, drug screening unless you really have a higher suspicion. Home sleep test is possible. Get that done faster than PSG, and echo is not needed. So your results of your PSG here were, and this was done at a time when you could get PSG pretty quickly. It shows that he has pretty bad obstructive sleep apnea. He woke out of a REM sleep instead of getting 100 million whirlwinds. He was fine. So which of the following issues should be addressed first? Insomnia and sleep apnea, paroxysmal nocturnal dyspnea and sleep apnea, BP, regulation of weight loss, active stance, possible nocturnal angina, upper airway anatomy, and people edema. I mean, we always talk about those sorts of things. We don't necessarily think about them in terms of the idea of what sort of pushes you into an urgent workup. These are all reasonable. These are all things that we do when we have people walk into the clinic. But which one is it? The active sleep is the possible nocturnal picture. I mean, those are the 2 things that really are alerting. Now, we have not put either of those things to other specialties other than sleep medicine and pulmonary medicine. Reason for that, from the 1993 and the 2000, or 93 and the 2004 ATS recommendations, is that those were the 2 specialties that had explicitly a section on sleep disorders in their training for fellowship and specialty treatment. There's no, in every other specialty, cardiology, even neurology, there is no particular notification on sleep disorders, but only in the idea is that fellows should not be sleeping. It's interesting still. That's not still not part of what people talk. So nocturnal angina is 10% of all patients with angina have OSA. Highest pretest probability. It has a beta blocker and nitroglycerin can be given before urgent cardiology consultation. So you can remember that, you know, do I now want to treat it or not? You could fall back on internal medicine principles. Paroxysmal nocturnal dyspnea, often no pain. In the sleep medicine literature, PND is sleep apnea until proven otherwise. That's what you have if you're go to altitude, you can't sleep. You have paroxysmal nocturnal dyspnea because you have periodic breathing. It goes away in 3 days. But that's what you have. Reflux usually have daytime symptoms or upper airway symptoms. They're hoarse, they cough, have it. And muscle and sternal pain with paradoxical chest wall movement. That's really interesting because there are some people that when they're placed when they have sleep apnea and they have a lot of they have weaker chest wall muscles, but when they have and they tug really hard, they really move their sternum moves. Now the one place where you'll find nocturnal chest pain as being a marker of sleep apnea is after open heart surgery, in which they have the sternal. They've separated the sternum and they do these mattress sutures. And it's too bad they don't ask them like a week after in their follow-up visit whether or not they have chest pain at night. Because what that is when they have a obstruct, their sutures just sort of like go back and forth, Placing people on CPAP, even if they have mild sleep apnea, sometimes helps. So those are sort of some odd things to think about. But in this particular instance, it's nocturnal angina. So each model predicts a different strategy to prevent disease. Sleep apnea is a causal agent, or sleep apnea is associated in point A to point B. So point A may be, I don't know, age 10, age 0, cardiovascular disability and death. And do you think that sleep apnea is a causal agent is important, or do you think that sleep apnea is an incremental associated agent? That's really what the issues are that still need to be sorted out. Now, I think it's an associated agent because there are people that have cardiovascular disease, disability, death, and cardiovascular problems that do not have sleep. So that's but it is a highly associated traveler. And I'm reviewing some things for talk to cardiology, and I'm going back to their original correlations between obesity, hypertension, and insulin levels, which there was a surrogate marker for pre-diabetes and for diabetes with insulin levels. And the article is 1965, Journal of Clinical Investigation. I probably none of the cardiologists that I'll talk to. I'll ask them whether or not they're aware of that. But it was a whole series of articles, mostly from Israel, that talked about that. And the idea of insulin levels being a common biomarker is there. We have insulin levels. So the Wisconsin cohort 1 and Sleep Heart Health 1 and 2, and then the SAVE was the idea you gave CPAP for sleep apnea. Was negative, it didn't have any effect. But that most of these had hypertension, cardiovascular disease that developed even if you did not have it, if your AHI was greater than 5 or greater than 15, more commonly greater than 15, or when the cutoff was 20, it was greater than 20. But in terms of trying to figure out which one has angina, there is no record here. I can't think of any sleep studies that I've interpreted that have been referred because of nocturnal angina. Can you guys? I mean, you guys have interpreted more than I've ever interpreted this year, right? Because you've been to 4 different centers and done a bunch of them each week and all that. Isn't that wild? 10% of all angina is nocturnal angina. So there are no practice guidelines. CPAP will reduce blood pressure, but only improve intermediate cardiovascular risk. Recent SAVE trial was inconclusive. And if I were an internist, could give beta blockers and nitroglycerin urgent cardiological consultation. I have no idea how they would know. Well, I do. I have an N of 1 person. Is my neighbor developed nocturnal angina 12 years after the quadruple bypass. He's an older guy, in his late 80s, and so he's not really a candidate for doing a lot of other stuff. But he talked to his cardiologist, and his cardiologist said, he probably has some sleep apnea. Go get one of those pillows that cost. So I set up a CPAP for him, he got rid of it. But he was getting up at night and taking nitroglycerin, but he had also angina. Active sleepiness. Sleepiness risk, drowsy, driving, crash, hitting a rumble stroke, differential diagnosis, have sleep time, depression, cognitive impairment, medications, comorbidity. So the second driving risk in OSA review in 2014, we discovered that there's a lot of other things that produce an increase in traffic accidents. And those are all those things: adequate sleep time, depression, medications, and even the medications for diabetes and hypertension. If you're on those, your crash risk goes up. And so sleep apnea is just another feature of these particular patients. So they have obesity, they have poor sleep, they have short sleep, they have inadequate sleep, they have medications, they have depression, cognitive impairment, all these sorts of things. So it's hard to kind of like just say that this, because they have OSA, they have a impairment. So there's only one study that I'm aware of, probably now more because it was a long time ago. The University of Pennsylvania took their entire cohort and looked and said, well, how many, what's the AHI cutoff for people who've had a car crash? Do I have any initial bids for you guys? I don't have a bid. Do I hear 5? Do I hear 10? See, we got bidding war here. We can even bet on the. If we had a betting board here and we put in $1, we could all win if somebody won close, huh? What do you think?
19.
15, 19. We got 19. Anybody higher than 19? Do we hear 25? Do we hear 25? Do we hear 25? So you guys are terrible. You're gonna be really bad when you get in an auction and have a lot of money and you want to buy a car. Oh, you'd be terrible. Terrible, right? Don't know how to bid. So it's 88. So why is it? Well, it's even, you'd say the car crashes there are narcoleptics. Well, how many narcoleptics have had car crashes? And it turns out to be about 45%. It's not 100%, which is sort of like, whoa. Now, do they have near misses? Sure. But in terms of having a real good crack up that gets on the board. And OSA is no different. There are probably little angels sitting on their shoulders, sort of telling them not to drive, whatever it is that says that this is how they do it. So education reportable, discuss management of the family, advise on lengthening sleep, and you can do the OSA patients that lengthen their sleep are not as sleepy. So they're sleeping now plan on sleeping 5-6 hours a bed because I've always only needed 6 hours a bed. Tell them to get in bed for another. sleep. State laws on reporting non-commercial drivers vary, and adequate OSA therapy will reduce risk. Now, the problem is adequate OSA therapy will reduce risk. The high risk is in the normal distribution of fall sleep car crashes in the United States. Mainly because the main reason for it is insufficient sleep. It's driven a lot by 18 to 25-year-old males. But the other is that we were against categorical reporting. There are 2 states that have categorical reporting. One is California, one is Arizona. California, if you have sleep apnea, you need to be reported to the county health commission. You go in for an interview to know whether or not you should be referred to the state driving board to have your license challenged. And the other is in Arizona, in which you go directly to the drivers and say, I have a diagnosis of OSA. You don't have to say that, and it varies as to what doctors know about it. So when that first came out, I was a major person in the American Sleep Apnea Association. Since then, not been as active because it's been taken over. Not because of that, but it still gives money. But a lot of it is now just patient-driven organization. They don't want docs involved. They want to be able to be an independent voice. But we have a lot of reports from patients, particularly in California, that have been reported to their local health department 18 to 20 times by different physicians because they had a diagnosis of OSA and the physicians thought they'd get in trouble if they didn't report it. So you can see all sorts of odd things in that one. Documentation, documented. How soon will treatment reverse excessive daytime sleepiness to this degree that is hitting a level? So they come in all the time. Doc, I'm really sleepy. I got this. I have to go back. I want to drive my truck. And it's been 1 week. I'm been using this thing. Well, show me you've been using it. Sure enough, they've been using it 5, 6 hours. AHI is nearly 0. They ready to do it? This doesn't feel great. You've seen the data. So, 1 night, 14 nights, and 42 nights. So about 2 weeks is probably better. And this is the MSLT. Now there's a variation, but that's the most precise study that's been done. It has its flaws, but you get an idea that 1 night will increase your MSLT by 3 minutes to 6 minutes post. So this is the data everybody talks about, the Weaver law, which shows your Epworth sleepiness scale gets better, it gets higher, it improves a lot more than MSLT or the FOSQ. FOSQ and MSLT subjectively feel a lot better. But the MSLT, if you do these studies, this was called, I think, the Apple study, which was a pretty big study. So, troubleshooting sleepiness. Duration, diagnosis. Go back to the beginning, did they have any cataplexy to be presented? You can have brain fog with severe sleepiness. Other sorts of things. You can actually have hypnagogic hallucinations with severe upsets. Relying medications, confirm penetration, measure CPAP efficacy at home, detect leaks. Now, important is if the patient was at risk before diagnosis, then you can reassess on it. What if they weren't at risk before diagnosis? Imagine if you were sitting there and you had sleep apnea, 20 years, right? You walk in and the guy goes, you got sleep apnea, you go through this. Now, you can get your sleep study and you have an AHI like 30. And the guy writes at the bottom, should not drive it away. So they say, oh yeah, you as Dr. Such and such, and he goes to 6 different clinics a week, can't drive a car. You said, well, I wasn't at risk, right? Haven't had a car crash. Not that sleepy. You know that the thing is 88 would be really sleepy. You'd feel pretty awful, wouldn't you? You'd probably even get a lawyer. You'd probably get that guy for all their work. So just remember, you have to, if they're not at risk before you assess them, you have, you can't kind of, that's one of the problems I have with some of the automatic assessments that we have. Because I always look at the Epworth. So the Epworth is not too high. If it's below 10, really get mushy, I say, well, if they have active sleepiness, you should have. That's, I don't know if that subtlety is understood by the physician.
I don't think it is understood.
So these are what is the change that happens in the Epworth Sleepiness Scale? The change is there, and that's how did improvement of 2 get to be there? Well, 2 is, that's mean is standard deviation. You see all the standard deviations. But it doesn't improve the sleep length. Now, there's been other studies since then. So this is 2006. So then this is the whole thing that started the modafinil story. 2007, 2003, modafinil came on. Never experienced a significant improvement in sleepiness, incorrect diagnosis, and CPAP associated conditions. Second gain. Patient initially improves, but after a period of time becomes sleepy and loss of previous compliance, weight, new condition. The most interesting one I got pitched at one time. Well, let's go to the last one. Honeymoon effect. That is, if you give them CPAP and they relieve their hypoxemia, they have a big surge of dopamine and serotonin for about 5-6 days. So they always go back and say, oh, oh, you will. You just have to kind of keep. But the other one is a new condition. The first one I got pitched, I was at Scripps with the guy I know who was a sleep doctor, really clinical, very, very bright. And he got me in front of it. I think it was the entire internal medicine group. And pitched me this case of a guy who came into Scripps for a reassessment of his sleepiness. And he had gotten sleepy 2 or 3 years before. He had sleep apnea, which was an AHI of like 22. And he didn't really like CPAP, but he never got any relief from it at all. I mean, he initially got a little relief, and then he didn't get relief. And it kind of kept going. Eventually, he bounced around the Bay Area, and he had 5 different sleep guys that did PSGs, because they did PSGs at that time, retitration. He finally came to Scripps, and the guy walked in the room, looked at him, said, "You need an MRI." He turned out he had 2. So I always sort of like, get to your. That was this guy. He was first an internist, and then he was a sleep doctor. So he walked in, and the reason was his left eye was drooping, and he just didn't look right. He had intermittent headaches and all that sort of stuff that was going on. So the diagnosis of sleep apnea was probably there, but it was really a distractor. So if you need to do more than one sleep study, you better think of some other condition. That bottom. Prevalence of excessive sleepiness with mean daily CPAP use. So this is a 2017, 8 hours a night, 9%. And this is what they all point when they go to Sorianta. And most of the time it's 7, 8 hours, right? It's 20%. So that's the market, that's the big market. So exercise is an adjunct. This is sleep and breathing, another one. CPAP plus exercise led to great improvements in sleepiness, less sleepy, less fatigue, better quality of life. Meta-analysis of 5 trials had a 32% reduction in AHI by fitness alone without a change in BMI. 8% improvement in PSG and efficiency and 28% reduction in self-sleep. That's quite an interesting approach. So that's why I always put fitness. So say fitness. Now, why would fitness do it? Probably being secondary effect of child, tertiary. Well, I can think of a couple of different ways. One is that you sleep longer. Longer sleep reduces your AHI. That you take, or as well as sleeping, that sleep restriction increases your AHI. So that's a problem. The other one is exercise. Exercise is not only your muscles and your legs and your chest and your breathing, but also your upper. So maybe it's a form of muscle activity. Or it could be that it reduces your it somehow reduces your, I'm trying to think of it, reduces your upper airway, like your nasal resistance or things of that sort. Now acutely it does. With a sympathetic vasoconstriction that goes. I think that's the role of exercise and sleepiness. Exercise training, postural shift, that's another one I was asked to put. What's your attitude towards this? You'll find a lot of different people have different attitudes towards the workouts. Too dangerous. It's interesting. Cardiovascular consequences. Now, in narcolepsy itself, if untreated narcoleptics have a lower blood pressure, a little bit lower, they're at the lower end of the population. And if you give them a alerting agent, they become sort of normal. And we did it in kids, not we, but Fanon did it in children and gave them Ritalin and increased their alertness. And found that the blood pressure went up during the day. For the 8 hours that the Ritalin was there, their alertness improved. They did better. And so the question, the existential question is, while Ritalin might produce greater sympathetic excitation, therefore increase your cardiovascular risk. Before Ritalin, they had no nocturnal dipping, right? The nocturnal dipping is a major factor, at least promulgated by cardiologists, that is a major factor of development problems. And so now that you gave them Ritalin, and their blood pressure is a little bit higher during the daytime, they had more, a greater proportion of the kids had dipping at night. So how about that? It goes crazy. Modafinil, so this is about the effect that you mean reaction time. Sleepiness. Document. So outcome treatment, for this guy was left anterior descending was stented before diagnosis. And there are now several studies that show nocturnal agent is treated by CPAP. But I was told when I presented this in the nineties and early aughts to the Department of Medicine, sleep apnea. Oh, no, we know how to treat that. We just said, what about sleep apnea? They go, that's your problem. So I tried to identify emergency sleep, cardiac ischemia, EDS. Those are the other two. What other symptom might be in it? Cataplexy? Maybe. I've heard of people having a cataplectic event, walking down the stairs to the basement, but they've not fallen. So because you're not cataplexy, you're not knocked out.
You're fully aware.
Yeah, you sort of know what's going on, and you know if you're in. And a lot of times you sort of go back and get against the wall and things of that sort. One of the more florid cataplectic patients over the VA that was subject to, this was before IRB, I mean, the IRB. One, I had a kid who wanted to be a cinematographer. He's a cinematographer in Hollywood. He followed along with this guy with his camera to document, and the guy went off his Ritalin for a day to follow what the narcolepsy looked like and what it felt like, and we'd interview him before and after the event and things of that sort. VA hospital and the name of the patient. Stuff. Yeah, didn't put it together. Still, I'm still in touch with it because his mother is a Democratic activist here. It's fun to jump. But he said that his experience was he would have a cataplectic event, and we would know whether the VA urgent care knew what cataplexy was, because he would have a cataplectic event at the VA hospital, and you hear, code blue, code blue in cafeteria, and we know that we were seeing him that afternoon. He was, oh my goodness, who is it? And he'd come up sheepishly about 2 hours later, said, yeah, I had one in the cafeteria, and they all, and then came to, but they already had him on there. They said somebody was about to resuscitate him and all that sort of stuff. And he got into there and they put him all the stuff in, and they asked him what happened. He said, I had a cataplectic. They didn't believe it. They took all the EKG, they took all the stuff, all this, they didn't believe it. So we fell down. He said, well, I couldn't move. He said, the one thing though, that you have to worry about, he didn't worry about it at the VA, because he could figure it out. He could call us, and we could get that. Say, no, it's just happening. He knows what. But he said he would go, he'd go to Walmart, he'd be walking around, and he'd get surprised, and he'd have a cataplectic. And in Walmart, same thing would happen. People would just go nuts. And he would really try very hard. And you can, one of our docs here used hypnotic suggestion to reduce cataplectic. So he did in a tube, but reminds me why we consciously decided not to teach you hypnosis. So there you go. That could be your next 10-year job. Do hypnosis. But anyway, he would have these events, and he would always try to get up and ready to go, because he'd be able to get it so that he was alert enough to say, no, I don't need any help. But they would always call. So he would get up and he'd get out of the store and get out of the place. Why is that? Well, if they came and picked him up and took him somewhere, he had to pay for it. But if they came and he wasn't there, Walmart had to pay. So that's how people do those.
Dr. Cecile has a patient that